Hi everyone, I am Dr. Tonya Welch and this is another fantastic episode of What's Up Doc. Now we've all heard the word fibroids, but how much do we really know about it? Now there's been medical advances worldwide, but we've also been impacted right here in Trinidad and Tobago. Now I'm going to talk a little bit about radiology. A radiologist is a medical doctor who studies scans. For example, CT scans, ultrasounds, nuclear medicine, and x-rays. An interventional radiologist is slightly different. I had the opportunity to sit with Dr. Robbie Rampersad, who's an interventional radiologist, and he gave us some really exciting insight into what interventional radiology is all about. Now, interventional radiology is something that is a relatively new specialty. Can you tell us a little bit about what interventional radiology is?
So it is, and we are very much familiar with what radiology is. So a radiologist is one who specializes in interpreting radiological imaging, medical imaging. So x-rays, CT scans, ultrasounds, MRIs. An interventional radiologist, you know, it's not the easiest thing to explain, but I think I like to explain it as a surgical radiologist. So it's someone who utilizes radiology or utilizes imaging to do minimally invasive surgical procedures. And it is a large part of what we do. So you're a radiologist, but then you use your specialty in imaging to do minimally invasive surgical procedures.
Absolutely. So, I mean, interventional radiology, training for it is quite a long process. Can you tell us a little bit about your process from medicine and then deciding to be an interventional radiologist, or radiologist first and then interventional radiologist?
Yeah, so the pathway to medicine is a long process, and you would very well know that and Trinidad versus the rest of the world, I think we sometimes have a shorter pathway in the initial period, but then that specialty takes us a bit longer. So medical school would have taken us 5 years of schooling, then a year of internship. And then after that, you then apply to a specialty program. So a specialty in radiology takes 4 years. In my instance, it took me 5 years. And then you want to start applying for fellowships to do interventional radiology, and that took an additional year. But the application process is sometimes somewhat drawn out. But in all, I would have started medical school in 2002 and then pretty much finished my training in 2016. So a total of 14 years, Takes some time.
So why interventional radiology? As you said, and as a lot of people describe, interventional radiology is described as the surgeons of radiology. But so why not open surgery as opposed to interventional radiology?
That's quite a good question, I loved surgery while I was in internship. I loved surgery as a medical student. I know it was quite a demanding field, but when I was exposed to radiology, I fell immediately in love as well. Yeah, it is such a unique specialty that is involved in everything. You have a chance to be involved in the pediatrics, in the obstetrics and gynecology, in the internal medicine, in the general surgery. You're involved with everything, but I thought that radiology and self-diagnostic radiology was a bit hands-off for me. Like I love interacting with patients. I love being in person-to-person interactions. I love relating to people, right? I think it's a very important part of medicine to me.
Absolutely.
It's a very rewarding part of medicine to me. And I thought interventional radiology was just the perfect mix of that as well as the radiology. Yeah,
absolutely. So we talk about interventional radiology, and as you said, it's something very complex to explain. But what are some of the common procedures that you would do here in Trinidad as one of maybe 2 or 3 interventional radiologists in the country?
Yeah, and the other practicing interventional radiologist, Fidel Rampersad, we both work together at Mount Hope. We also have Dr. Rodney Ramroop, who has been administrative for a long time, and he doesn't do as much practice in interventional radiology as much anymore because, very important work in administration as well. So Fidel and I have been trying to, get more and more stuff done, because a large part of what we do even is not known to our colleagues, right? So that's part of the challenge as well. But currently, a huge part of our practice is definitely dialysis access, vascular access. So catheters for patients who require dialysis, vascular access, people with difficult accesses for chemotherapy, and for various other things that require vascular access. And a large part of it, I think, would be biopsies. In our current setting where I just feel like there's an explosion of cancer cases. Biopsy and image-guided biopsy has become a huge part of what we do. Previously, when a patient required an open surgical biopsy to get a diagnosis, what we can do now is use ultrasound or CT. Because we can visualize where the area of interest is, we can now utilize those imaging without having to do a surgical incision. Yeah, we can pretty much use local anesthetic and go through the skin and get to the area within whichever organ, the breast or the kidney, the liver, or whichever we need to.
Yeah, absolutely. So there's a particular procedure that has currently gained traction and has become more popular, uterine artery embolization. I'm going to ask you a little bit about that, but before we get into that, we're just going to take a quick break.
Uterine fibroids are non-cancerous growths that develop from normal uterine muscle cells. There are 4 types of fibroids that develop in or just outside of the uterus. Submucosal fibroids grow into the uterine cavity. Intramural fibroids grow within the wall of the uterus, and subserosal fibroids develop on the outside of the uterus. Pedunculated uterine fibroids occur when a fibroid tumor grows on a stalk, resulting in pedunculated submucosal or subserosal fibroids. All fibroids require a supply of blood to survive and grow. UFE takes advantage of this fact to target the fibroids.
Welcome back to What's Up Doc. I'm here with Dr. Robbie Rampersad, Interventional Radiologist, and we're talking a little bit about a very interesting specialty, Interventional Radiology. And we're back and we're talking about a common procedure, and it's called uterine artery embolization. Dr. Rampersad, you know, this is related to fibroids, and women with fibroids have had a long history of very difficult, heavy periods. Tell us a little bit about what uterine artery embolization is.
Yeah, and I'll tell you, Tonya, like, even for me, the problems associated with fibroids was not really understood until I started doing interventional radiology. So because it's a non-cancerous problem, you always think, okay, it's not serious, it's not significant, and it's passed off as, okay, it's just a problem that women deal with. But I've seen patients now who, I remember our very first patient at Mount when we started this program. She had to quit her job because of her heavy bleeding, and she would often soil her clothes. So she couldn't deal with that anymore. She had quit her job. The income problem had led her into a bit of depression. She had just gotten out of a difficult relationship, and it was a really, really messy time for her when I first saw that patient. And embolization in her case was life-changing. But I very well remember the name of that clinic in my fellowship. We used to call it the Hug Clinic, because when you see those women after 3 months, they often want to jump and hug you because it's made such a difference in their lives. And treating fibroids has taken an abrupt about turn for me since we've started doing this. And it is something I'm very, very excited about.
Yeah, absolutely. I mean, like you, I've heard many stories, success stories. And I'm sure a lot of people are interested to know, how exactly does this work? Yeah,
so what is embolization? Embolization is effectively, it's a method without cutting, without having to do surgery, to block something. So in our case, it's most likely blood vessels. So fibroids are non-cancerous tumors that sit within a woman's womb. And they cause tons of problems, from pain and bleeding and tons of different problems, yeah? So the whole idea is, traditionally we would have taken out the entire womb to treat with fibroids, or taken out the fibroid themselves surgically, right? And that's still an option that needs to be practiced and needs to be exercised in a lot of patients,
cases,
yeah? But there is an option of embolization in a lot of women who suffer from fibroid disease, and that is utilizing a needle stick and using a combination of tubes, dye, and certain particles to block blood vessels, get to the blood vessels that supply the fibroids and block them from within. And if you block the blood supply to the fibroid, what happens is you effectively kill the fibroids without ever having to open and remove the fibroid. Obviously, it doesn't happen as immediately as surgery, because what you're doing is you're blocking the blood supply and you're asking that the fibroid is now killed slowly because of a lack of nutrition to the fibroid. What happens is the symptom improvement is, in the majority of cases, almost immediate. So by the next cycle, by the next period, you have improvement in your symptoms. And you have shrinkage of the fibroids, typically about 50% of the volume of the fibroid within 6 months. And then they continue to shrivel and die. Yeah, so it's a method where we can treat multiple fibroids, because when we're treating the fibroids, we're treating all within the womb at the same time. Treating multiple fibroids without surgery. Yeah.
Now, it sounds like such a fantastic procedure, probably almost too good to be true.
All right.
Does it come with any risks or complications?
Yeah, some people tell me this is obia, you know, it sounds so good, yeah. No, but what is important, and we always have this conversation with patients. This may be the right thing for you, or it may not be the right thing for you. You may require surgery, or this may be an option for you, right? Is this the right thing? And you asked about risks, right? And the longest part of the conversation when I'm doing a consult with a patient for this procedure is that risk of infertility. Yeah. Does it carry infertility risk? It does. That risk is rather small. And I don't have the exact figures when I say I, meaning the interventional radiology field, just yet. What we know is, in a woman under 40, it is less than 5%. In a woman over 40, it is less than 15%. And when I say less than, this procedure is only about 25 years old. When we first started doing this procedure, we used particles that were much smaller, which we don't use anymore. But back in those days, when the risks would have been higher because of the size of the things that we use, that was the risk, 5%.
Right.
Now, it is not 0%, but I can't tell you between 0 and 5 where exactly that is.
Where it is now.
I feel it is closer to 0. It's not 0, definitely. But yeah, it's overall, for all women, we quote typically about a 7 to 10% infertility risk.
But what about the procedure would render the woman infertile?
Yeah, so when we are doing an embolization, we're effectively blocking the blood supply to the fibroids by using particles from within the blood vessels. Now, this process, you know, we would ask, how do we not block the blood supply to the normal womb? And it has to do with the particle size that we use for the embolics, or the particles that we use in the procedure. And sometimes, or in rare occasions, based on the particle size, there can be some blocking of the arteries that supply the ovaries as well. Now, since we started using a particular particle called gel phomosurgical sponge, which we use very widely in Trinidad now, and it is what we use across the board in Mount Hope, we've not seen a single ovarian failure.
Wow.
Right? It is a remarkable particle. It has a slightly less success rate. And when I say slightly less, meaning instead of the low 90s, we get high 80s.
Okay.
Yeah. So a slightly less success rate compared to the other particles, but the safety profile is much more. And I like that as well. And I think it's something very sustainable to use in Trinidad.
Yeah.
And we can make it much more available to a lot more women with this particle.
Absolutely. I mean, this is great news for women. As you said, we don't really pay attention to fibroids and how difficult and how much women's lives change when they suffer from fibroid disease.
No, and I'll tell you, Tonya, like Caribbean women, they have like particularly severe fibroid symptoms of fibroid disease.
So we're talking about a very groundbreaking procedure for women who suffer from difficult fibroids. It sounds like it happens very quickly. It's safe or relatively safe.
Yeah.
What about the immediate time right after you've had the procedure? What is it like? Is it a quick return to work? How does it compare to a full surgical procedure?
And we often have this conversation with women again because they want to know, like, I can't afford to have a long downtime. So because it's not a surgical procedure, we're not doing an open incision. Time to back up on your feet is much faster. All right. Now, is the procedure a painful procedure? Yes, it is. For about half of women. And I can't predict which half of the women that will be.
Yeah.
Right? So for half of the women, it will be as painful as probably having your womb removed, right? Pretty bad pain. And that's why we use a lot of different painkillers during this procedure. So it's not a procedure that you will come in to the hospital and have and go home immediately after. We would usually keep you overnight for pain relief.
Yeah.
Yeah. But that pain in most women would dissipate by the day after or 2 days after surgery, such that you're back up and walking. And because we want you up and walking. Typically, we would give women 2 weeks sick leave after this procedure, just to take it easy, catch yourself, get back into some activity. But most women are back to almost their regular activities by 5 to 7 days.
Yeah. Yeah.
And that's a big benefit. I think
it's fantastic.
It is.
5 days post-procedure is just such a fantastic time period that you're dealing with.
And even in the first few days after, it's not that you can't, right? Because we're encouraged to be back up on your feet by the next day.
Yeah.
Right? Some women are back up on their feet the same evening.
Right.
Yeah.
But you may get some tenderness.
Of course.
Or some,
and that's the thing. Some pain and that sort of thing. Before you can return to going back to your gym or your regular activities, we advise usually a week or 2 weeks before you start doing that.
So you said since it started at Mount Hope, there's been 0% ovarian failure.
So not even at Mount Hope. So at Mount Hope, we haven't done a ton of procedures just yet. We've probably done just under 50 probably at Mount Hope over the last 3 years. But there's a English professor by the name of Nigel Hacking who has been doing this procedure in Trinidad since 2000. And he's actually done over 1,500 cases in Trinidad. So 1,500 women would have benefited from this before in Trinidad, even before we started back doing it at Mount Hope. And he is actually a world authority on this procedure. He's published extensively on this particle called gel foam that we've been doing. And he as well has not seen a single ovarian failure from this. So that has me pretty excited. It is not terribly widely used across the world, but his research is pushing us in that direction. And we are starting to use that particle as well.
I mean, this is great news for women. As you said, we don't really pay attention to fibroids and how difficult and how much women's lives change when they suffer from fibroid disease.
No, and I'll tell you, Tonya, like Caribbean women, they have like particularly severe fibroid symptoms of fibroid disease. Even during my fellowship in Canada, the worst fibroid patients, when I say the largest fibroids and the patients with the worst symptoms, were almost always women who immigrated from the Caribbean. Yeah. And I think as probably as much as 1 in 3 women would have fibroid symptoms, have some sort of intervention. And it's not meant to replace surgery or it's not meant to replace conservative. So if you have a fibroid and you have no symptoms, this is not for you. Surgery is not for you. But if it's affecting your life and you see a gynecologist and something needs to be done, this is definitely an option that should be there for you and you should ask about and you should entertain.
Absolutely. So great news. Fibroid, women suffering from fibroids, this is a great alternative. So just to finish up, Dr. Rampersad, we're talking about interventional radiology. We spoke about uterine artery embolization. And you also mentioned a little bit earlier about cancer treatment. Can you tell us a little bit about some procedures that you use for treatment of cancer?
Yeah, so we're very much involved in treatment of cancer. And when I say involved in treatment, interventional radiology provides a lot of support services. So in addition to the biopsies we mentioned before in terms of diagnosing, particularly for chemotherapy, I would say portacats are a very important thing. That yes, we've been doing it, surgeons have been doing portacats for some time now, but since interventional radiologists have been doing it, it's less invasive. And a portacat is a device to allow for chemotherapy delivery. Yeah. But there's another part in terms of treatment that we're involved in, and it is for certain types of cancers. Actually, just this week we had one patient who benefited from this, and it's a procedure called TACE. It's transarterial chemoembolization, and what it is effectively is a patient who had a liver cancer. And instead of giving chemotherapy to the patient with the host of side effects that comes with chemotherapy, if it is, we can deliver the chemotherapy directly into the liver at the tumor. You can give a higher dose directly at the tumor, so it's more targeted with less side effects to the rest of the body. So what we do is, similar to the fibroid, we do a needle puncture to one of the main arteries, and we pass a little catheter or a tube up to the area, and using in a fancy lab called a catheterization lab, we get up to the tumor within the liver. So now we're not talking about the entire liver, we're talking about to the tumor. So this is sparing the rest of the liver. And when we're at that point, we deliver the chemotherapy directly into the liver at the tumor, and then we decrease the blood supply afterwards via embolization, just as we do in fibroids. And what it does is allows the chemotherapy to sit there and to work on that tumor. And this is some of the exciting developments in interventional radiology. It's been around for some time, but this is one of the things that we do as well.
And locally as well.
Yeah. So I would say we were, so for procedures like TACE, only since Fidel has been back since 2012. I've been back in 2016, and we've benefited from these sort of things. We have another interventional radiologist, Cassim, who'll be back in December. And our hope is always that we inspire and we can get some young radiologists who would love to do interventional as well as a pathway. And hopefully we can get a full cadre of interventional radiologists in the country, probably 10 or so within the next decade.
Fantastic. I mean, interventional radiology is just exciting. It's new. And I'm so happy that you could have shared with us what it's like to be an interventional radiologist and some of the main procedures. So Dr. Rampersad, thank you so much for joining us.
Thank you very much for having me.
And hopefully some woman out there who has fibroids could come check you or check us at Mount Hope.
Yeah, I think the important thing is for the knowledge to be there, for women to understand that there is an option called embolization. And speak to your doctor about it. Speak to your doctor. It may or may not be what is right for you.
Absolutely.
But at least entertain it as an option.
Absolutely.
Yeah.
Thank you so much. You were tuned in to What's Up, Doc?